The following episode is brought to you by the American Urological Association. This special episode comes to you from the AUA Update Series, Volume 44, Lesson 9, Congenitalism, Transitioning Patients with Congenital Urological Anomalies from the Pediatric to the Adult Care Setting. The AUA Update Series is renowned for delivering high-quality lessons to practicing urologists, fellows, and residents. All content is developed by internationally recognized experts in urology, making the AUA Update Series the most professional and sought-after self-study program available. Improve your practice and patient care by staying abreast of the latest treatments and surgical techniques in urology.
AUA Update Series, Volume 44, Lesson 9, Congenitalism, Transitioning Patients with Congenital Urological Anomalies from the Pediatric to Adult Care Setting. Authors Dan Wood, Ph.D., MBBS, FRCS, and Aaron McNamara, M.D., MPH, FAACP. Introduction. Healthcare transition is the planned movement from a pediatric family-centered healthcare model to an adult patient-centered care model. As children reach adolescence and young adulthood, it is recognized that they need to start engaging with the medical system and their healthcare with an aim of greater independence. Over the last 20 years, urology has been more invested in establishing a transitional care model within our specialty. Patients with congenital urologic anomalies and some acquired issues are living well into adulthood and require ongoing care. Advances in medical and surgical care have greatly impacted survival of pediatric patients with congenital urologic anomalies. The pediatric urologist is trained in these pediatric conditions, but either lacks training in adult-related issues or is unable to care for these adult patients at their institutions. Most adult urologists do not have extensive training in congenital and pediatric conditions. This has led to a crisis in caring for these patients. In response, urology as a specialty has acknowledged the importance of caring for these patients into adulthood. In 2015, both the AUA and the National Institute of Diabetes and Digestive and Kidney Diseases established a Congenitalism working group to identify areas of research needed in transitional urology. In the last 2 decades, we have seen the evolution of transition models in clinics in urology, increased research on the barriers and challenges in transition, and continued dedication and innovation in caring for this vulnerable patient population that requires lifelong urologic care. Challenges with transition care. The most straightforward model of transition care is demonstrated by the need to change from a pediatrician to an adult primary care physician. For those with minimal medical issues in childhood, this would seem to be a straightforward transition, and yet research has shown that there is a lapse in care in young adulthood that leads to negative health and social outcomes. As medical complexity increases, there are increasing challenges in transition. Children with special healthcare needs are engaged more with the medical system. However, they require multidisciplinary care and therefore a multidisciplinary transition. The most common example in urology is patients with spina bifida. During childhood, they may see 3 or more subspecialties, medical and surgical, and require continued follow-up into adulthood. Many spina bifida centers attend to the needs of the family and pediatric patient to coordinate care, decrease hospital and clinic visits, and attempt to address the entire patient. Developmental medicine, neuropsychology, occupational therapy, case management, and social work can all be integral parts of a pediatric multidisciplinary clinic. This model rarely exists in adult medicine, except in cancer care. For example, it can be increasingly challenging to find a neurosurgeon and a urologist at an adult institution with an interest in caring for this patient population. Thus, care can become fragmented instead of coordinated. To summarize, pediatric care involves a multidisciplinary team, is family-centered, permits limited independence, provides intensive coordination, has more psychosocial support, and has active follow-up. In comparison, adult care is rarely multidisciplinary, is patient-centered, expects more independence, has limited access to psychosocial resources, and has more passive follow-up, directed by the patient. What are the barriers to transition in the complex urologic patient? Many studies have looked at this from the patient perspective, and a few studies are from the institution and provider perspective. The most common patient barriers fall under the following themes. Number 1. Relationships. Difficulty with leaving the pediatric provider who knows the patient well. 2. Access and insurance. As children age out of their parents' insurance and Medicaid, they are reliant on public or private insurance if they are able to find a job with insurance coverage. This decreases access to providers, and as insurance changes, this can make it challenging to find providers who specialize in these needs within a network. 3. Beliefs and expectations. Negative views on adult care or negative interactions with adult providers. 4. Knowledge. Being able to navigate the healthcare system. 5. Skills or efficacy. Independent self-care. In addition to the medical domains that are important to address during transition, there are non-medical domains, including education, employment, and independent living. This is challenging for our patients with physical or intellectual disabilities and can lead to delay or even halt the transition process. From the provider and institution perspective, the most common barriers are 1. Varying practices and opinions around appropriate transition age and care among urologists. 2. Inability to provide multidisciplinary care. 3. Paucity of adult providers who are trained to care for these patients. 4. Lack of clarity around which subspecialty should assume care. 5. Lack of a formal transition plan. 6. Financial burden and resources. Role of transitional care programs. Patient selection. There are no absolute exclusions to the need for pediatric to adult transitional care. The increasing complexity of a condition makes the need more likely. Whether a single system condition, for example hypospadias, or a person with multiple organs affected, the need may be just as great. Conditions affecting patients who may need this care include congenital, such as bladder exstrophy, cloacal exstrophy, posterior urethral valves, spina bifida, hypospadias, severe or multiple surgeries, cloacal anomalies, and differences in sex development, and acquired, such as trauma, some pediatric tumors, and transplant. The need for transition may be an underlying requirement of the condition, for example spina bifida or posterior urethral valves, where bladder and renal function may change throughout life and need to be closely monitored to decrease morbidity. Many of our patients with congenital urologic anomalies are managed with surgeries, such as bladder augmentation and/or the creation of a Mitrofanoff channel, which necessitate transition care. When designing and/or negotiating a service, it is important that all stakeholders are involved. Both the healthcare team and the providing management or administrative support need to understand some important principles. The aim of the transition program is to have long-term monitoring and follow-up for patients with chronic conditions. Some will need revision surgery, some will need to be seen by multiple specialties, and some may be seen on a regular basis but need no intervention at all. There is little to tell us which patients are likely to fall into each of these categories. It is easier to know which patients are more severely affected, number of surgeries, poor renal function, etc., but harder to know which of those more mildly affected will develop any form of complication or deterioration in adulthood. There will inevitably be a continued rise in the number of patients joining the transitional urology clinic, and for all the reasons above, a far lower number of patients leaving the service. When comparing widely used parameters, for example new to follow-up ratios, those data need careful interpretation. With the tendency to increase patient numbers coming through the service, real consideration needs to be given to the sustainability of the service and the ability to continue providing effective and timely reviews and intervention for patients. Failure to anticipate these risks may cause a shortfall in capacity, resulting in overbooked clinics, delayed reviews, and difficulty in scheduling interventions, the sum of which may result in direct patient harm, despite everyone within a service working at the best level possible. Critical elements in the transition process. These are well described on the GOT Transition website. It is essential to have a cohesive policy explaining expectations and goals that provides a way to track patients to make sure that they are being seen appropriately. This detail is important in setting up and running the transition program. Terminology is often focused on the transfer of care, and this is mistakenly spoken about as transition in itself. It is one element, but by no means the only aspect of transition. In fact, if this is allowed to be the major focus, the transition program will not be successful. It has been helpful in our practices to simplify details in order to highlight the importance of the overall process rather than any one of the 6 elements. It is easy to frame transition under the 3 P's. 1. Preparation. In many ways, this is the most important component, teaching a young adult how to manage and develop their independence in healthcare. This can be supported by one of the preparation tools that are readily available and can be incorporated into an electronic healthcare record. One example of a tool is the Transition Readiness Assessment Questionnaire. The move from pediatric to adult healthcare may have some inevitable bumps, most notably because pediatric hospitals tend to be better at wraparound care, whereas adult hospitals assume independence. Even though each provider may be offering the same levels of care, patients and parents will experience this difference. In order for the transition program to be successful, expectations must be set, and these differences must be explained. 2. Plan. It is important to know what the pediatric team has been focusing on and what they perceive as the ongoing needs going forward. When a patient meets a new team, even the most ringing endorsement does not create instant trust. Patients may take time to reveal some of their greatest concerns until they have developed confidence. And if a situation is complex, they may not recall all of the important details. An ideal setup is to have joint appointments at the pediatric and adult centers, allowing for the sharing of concerns and agreement of the plan going forward with the patient, the pediatric team, and the adult team together. This may not be practical in all settings, and alternatives, such as a health passport, containing pertinent medical information and the likely plan may act as a substitute. 3. Provider of the future. It is no longer good enough for pediatric providers to end care for a patient without negotiating someone to continue their care. The need for ongoing care should be something that a pediatric team seeks to find, and if it does not exist, their lobbying should seek to establish it. Timing of transition. Ideally, conversations about adult care should begin once a congenital urologic anomaly or acquired condition is recognized. Many parents will have questions about long-term care, including topics such as fertility potential and sexual function. Involving a child in the healthcare discussions can begin at any age and may help them to build their own decision-making capacity. Certainly, as they enter teenage years, working toward transition should become a part of healthcare discussions so that there is no delay in preparation. For some, they will be ready to transfer relatively soon. Decisions around exact timing will relate to the psychological well-being of the young adult and a judgment about readiness. Use of transition tools may help with this. This is balanced against the medical or surgical readiness of the person. Ideally, transfer to an adult setting should be managed in a time of medical stability, the exception being pregnancy, as this will necessitate the need for involvement of obstetric providers and potentially adult urology, depending on admitting rights and local setup. Outcomes. A detailed discussion around outcomes is beyond the scope of this lesson. One of the difficulties in justifying transition programs is that they are largely about maintaining a status quo and preventing deterioration. This is very difficult to measure, as described in a report by the Agency for Healthcare Research and Quality. This report recognizes the need for training and development in this space across specialties and challenges us to produce better data. One of the conversations that is really starting to gain momentum is around the subject of medical post-traumatic stress disorder. For those of us working closely with these patients, we recognize the need for adult psychological support, as there are increasing examples of older patients suddenly needing to confront the psychological accumulation of trauma, even through the best medical care. There is almost nothing written about the psychological impact for these patients. Many have recognized the need and argued for psychosocial support in the past. It looks likely that this will be an area of focused development in the future. How to develop and implement a successful transitional care program. Ideal model. The correct or ideal model is the one that will work in a particular clinical environment and health system. What is more important are probably the elements of transition. Some examples of potential frameworks are given below. Where the pediatric and adult urology departments are combined. This is most common when pediatric urologists continue care into adult life because they are in a health system where they also have privileges in the adult setting. There are a couple of potential advantages to this. 1. Absolute continuity eases some concerns for patients and their parents. 2. The pediatric urologists are able to follow outcomes long-term, recording their own data and modifying their own techniques accordingly. 3. This may allow for integrated work with adult colleagues as long as the pediatric urologists and reciprocally the adult urologists are appropriately credentialed. However, pediatric urologist careers will be shorter than the lifelong care needed for the vast majority of their patients. Therefore, these patients, who will have formed a strong bond with their surgeon, will have to move to a new doctor. This may be less traumatic in later life for the patient. There is no evidence that one is better than another, but it is worthy of consideration. To continue care in a purely pediatric environment may not be healthy for either the patient or other pediatric patients in the department, where the pediatric urologist integrates with the separate adult urology department. This also maintains continuity. In both models, it is important that the pediatric urologists are fully aware of both the original diagnosis and the treatment. Also, in integrating with adult colleagues, they must continually consider whether they remain the best person to look after their patients. It is important that they maintain the links and the humility to hand over patients to other appropriate experts when it is in the patient's best interests. The further challenge for pediatric urologists looking after adult patients is the need to integrate with adult specialists outside urology, including nephrologists, radiologists, endocrinologists, and gynecologists. This may be a greater challenge in an adult setting rather than the first. Both are achievable, as evidenced by those who have succeeded. Transition from the pediatric urologist to an adolescent or adult specialist with an interest in this area. This requires an interested adult urologist. The practitioner must understand the pediatric diagnosis and treatment. They must have spent time working in a specialist pediatric center and/or developed a training in reconstructive urology. This urologist must be focused on the overall care of the patient and cooperate effectively with specialists in reconstructive surgery, endourology, andrology, and gynecology. The challenge is the coordination and initiation of transition. The adult practitioner is reliant on the pediatric colleagues preparing patients and the parents for both transition and the transfer of care. In turn, the pediatric urologist needs to develop a trust in the individual taking on the care of the patients. There needs to be some form of joint clinic and an active process that allows patients to know what is happening to them. Views will differ, but allowing patients to meet their new providers in the pediatric environment, i.e., that is most familiar to the patient, seems ideal and creates the opportunity to agree on a future plan. Direct transfer from the pediatric urologist to adult urology. This suggests a lack of the fundamentals of transition. 3 Ps: preparation, plan, and provider of the future. It is true that many patients exist in this kind of environment, and it probably results in poor communication and increases in difficulties with patient access. There is increased potential for use of emergency rooms or services unfamiliar with their care needs. The informality may also prohibit training in this area for those interested in developing it. Many adult urologists have little interest in looking after patients born with spina bifida or other neurological problems, and when confronted with a patient who may have had several surgeries for exstrophy or epispadias, severe hypospadias, differences of sex development, reflux, or other obstructive uropathy, they can feel intimidated. These patients have chronic conditions about which they are usually very well informed. Therefore, treatment decisions need detailed explanation, requiring medical and surgical expertise in that area. Experience of the authors. The experience of the authors differs at their respective programs. One of the authors is not associated with a single adult urology program. For this reason, we have partnered with interested adult reconstructive urologists across the city and region who are interested in caring for these patients as they reach adulthood. More importantly, we have a complex care team that helps coordinate the transfer of care not just from urology, but from all the subspecialties needed. The complex care nurse practitioner has several visits with the patient leading up to the transition to make this a more seamless process. This has been most successful in our spina bifida center, but we still face challenges both there and with other congenital anomalies. There can be a large role for the advanced practice provider. The other model that is represented by our authors is the concept of an adolescent or adult specialist. This urologist is trained in both pediatric and adult reconstructive urology and has developed an interest in the adolescent and adult patients with congenital anomalies. The practice is based on a referral pattern from the pediatric urologists who are graduating the patients to adolescent or adult care. This model can be very effective, but requires a urologist with an interest to make this almost their entire practice. It has been shown that the need is there, especially when associated with a busy, complex pediatric practice. As stated above, the ideal model needs to be crafted based on the environment in which the urologist is practicing. There is room for innovation. Development of a care team and implementation strategies. In those patients with a substantial urological need, the person acting as the adult urologist may not only become the urologist, but also function as the primary care provider in some cases, often serving to bring in additional services when needed. Ideally, the patient will also have a primary care physician who can serve as a vital link and, when possible, help to navigate some of the difficult decisions in their care. Establishing a link with a patient's primary care physician can be immensely helpful for all parties. Finding a primary care physician in the current state of medicine is a challenge for patients without complex medical needs, and this is only compounded when looking for a primary care physician who will feel comfortable navigating the world of congenital anomalies in adulthood. Those who are trained in medicine and pediatrics may be a source for primary care. There are complex care fellowships, but many of these physicians are focused on pediatrics. In an ideal situation, the patient's own primary care physician will help facilitate and coordinate local specialty care. Working with other specialists is also essential. In urology, we work closely with colorectal, gynecology, nephrology, radiology, endocrinology, and psychiatry specialties as examples. It is more common to find these links established in a pediatric setting, but direct and deliberate legwork might be needed to find these links in the adult world. These patients are complex, and as discussed above, if a transition program is established, the number of patients will grow. Many urological partners will be less familiar with the conditions seen in an adult congenital service, but there need to be colleagues who can share some responsibility for these patients. For a service to be sustainable, each member of the team needs to be able to take uninterrupted leave or vacation, and there must be someone who can deal with ongoing or urgent inquiries while a team member is away. Patients probably get better care when complex decisions are being made by shared decision makers. This also opens the way for joint operating to best manage patient complexity. In short, there are many arguments for a colleague to share in this work. It is impossible to overestimate the value of good nursing support. This may come in a variety of forms. Specialist nurses are very important in managing particular areas of care. For example, the management of ostomies and stomas. Advanced practice providers have an increasingly important role in providing independent care for patients in both outpatient and inpatient settings. They also can play a role in preparing for the transition from a young age, as they can have separate visits from the surgical visits. How each of these is deployed really comes down to the local setting, but they are needed for good patient care. Continuity is an important part of the transition program. If providers are working in both pediatric and adult hospitals, they should ideally have a team that moves with them. Coordinating complex care packages is greatly facilitated by this. Children's hospitals are generally good at the provision of multidisciplinary clinics. Adult centers may have these in some settings, for example oncology, but they are less widespread. So while there may be limited opportunity to have multiple providers in one setting to see a patient, a complex care coordinator may be able to facilitate multiple appointments within a defined time period to minimize the number of patient visits to the same hospital. Financial and administrative considerations. This is a recognized barrier in creating a transition program. Financial burden and high utilization care with low compensation are concerns for adult providers, departments, and hospitals. The majority of these patients are likely to have public insurance and utilize emergency room and inpatient care at higher rates than the general public. Each hospital system is different, and while there is a sense of duty to care for this vulnerable population, there are financial pitfalls that make this prohibitive. Other lessons learned. Barriers vary according to the healthcare system and/or environment. Both authors are fortunate to work in institutions that have shown the foresight to recognize this area of need and support the development of urological transition programs. Barriers still exist. Being able to engage the patient and family in the process is the first hurdle in transition, and this can vary amongst families. It may be that the opportunity to visit the adult clinic prior to transition serves to remove some barriers. Being dependent on a single pediatric or adult provider for transition is problematic and can set back the progress of the transition if one of these providers leaves. Creating a program is a labor-intensive endeavor. These issues highlight the need for a set process, a team approach with all care providers, and engagement from the adult side of care. Ultimately, we have to consider what provides the best care for the aging patient with congenital urologic anomalies or acquired issues. Transition is undoubtedly improved when the need is recognized and a program is developed. Conclusions. The principle and the need for transition care for urological patients are established. For many patients, there continue to be considerable barriers that may obstruct a seamless progress through this process. Support of a patient and the family by helping them with preparation for independence in healthcare is vital. It is helpful for institutions and providers to ensure clarity by making a plan for future care and for someone to deliver that care. Adherence to these principles will facilitate transition for a patient, and as providers establish this as part of their practice, gathering data to provide clinical outcomes and service line information will serve to strengthen the justification for this care into the future. Did you know? Transitional care programs are essential in urology for patients with congenital urologic anomalies and acquired lifelong issues. Barriers to care may arise from both the patients and the providers or institutions. Transition care programs need to be tailored to the respective practice or medical system. Engagement by all stakeholders is key in establishing a successful transition program.
If you enjoyed this lesson or would like to know more about the AUA Update Series, please visit the AUA University at auanet.org/university.